everybody. Welcome to this 22nd episode of our podcast Blood Matters, a podcast for nurses, where we explore the latest insight in pediatric acute leukemia and hematopoietic stem cell transplant and cell therapy. My name is Hilda Mekelenkamp, and my co-host today is Chalmers. And today's episode is divided into 4 parts, each shedding light on different aspects of caring for children with acute leukemia. Our guest today is Thomas Jezequel. He is a pediatric advanced practice nurse with a huge experience and expertise in transplant and cell therapy care. And we are very happy that you joined us today, Thomas. And please, can you tell a little bit more about yourself and what you do?
Okay, hi Hilda, hi Hema.
Hello.
Thank you so much for inviting me to speak on this fantastic podcast. As you mentioned, I am an advanced practice nurse in the pediatric hematology department at Nantes University Hospital in France. I started my career in this field about 15 years ago, and I completed my master degrees as an APN 5 years ago. And I am currently involved in the care pathway for children, adolescents, and young adults undergoing hematopoietic stem cell transplantation with a particular focus on a post-transplant follow-up in outpatient care.
So thank you so much, Thomas, and happy to have you with us. And Emma, also happy to have you with us today. How are you doing?
We haven't done one together for a little while, so it's exciting. And welcome back to the podcast, Thomas. You were here before, so
yes,
very happy to have you back. This time talking about your topic of expertise and not just the previous annual meeting. So I want to start this off by asking you to tell us some myths and realities of looking after pediatric patients with acute leukemia. Tell us what's going on in the world and what's right and what's wrong right now.
Okay, for the pediatric patient, we have to know that we commonly have more acute lymphoblastic leukemia than acute myeloblastic leukemia, which I think it's quite the opposite for the adult patients. But we have fantastic overall survival rates for acute lymphoblastic leukemia, I mean for children. We have some discussion, concern about conditioning regimen prior to transplant, which is also quite different than in adult patient, because usually we perform some myeloablative conditioning regimen, and this expose the patient to long-term side effects, which is probably quite different than for the adult patient. So that's, can I say, as an introduction.
Brilliant. And I suppose, as far as I understand it, there's a move away from, well, not away, that we're still using transplant, but CAR T has obviously become huge in treating leukemia in pediatrics. So how has that been in the last sort of few years?
Yeah, I mean, it's for me the most significant and meaningful development since I began my career 15 years ago. Definitely the advent of target therapies, but also CAR T cells therapies, which have drastically changed the landscape of leukemia treatment by offering some curative options to patients who at one time, in case of refractory or relapsed disease, unfortunately had no other option than palliative care. So definitely it changed the landscape for this patient. And it's amazing as a nurse to be able to see this changement.
Oh, CAR T, I still think it's one of the coolest things we've ever done, personally. So do you think this is probably one of the biggest major changes in pediatric care for leukemia patients?
Yes, for me it is.
Few years? Yeah.
Yes, for me it is. But it's also involved a lot of challenges, questions. So it's very interesting.
Yeah, and I think it also changed the role of the nurses very much, because it's a very different therapy. Not very different, but it is different from HSCT.
Yeah, and really when this therapy comes up, we had to adapt. The nursing profession has to adapt very quickly, has to train to be able to take care of this patient very quickly. So it was a nice experience as a nurse.
And how was it for your team, all those new experience? Did you remember how they adapt to all those changes?
We created some nursing group dedicated to these fields, CAR T cells. So we trained them to understand the mechanism of CAR T cell therapy, and then they were the first who are able to take care of those specific patients. And after that, we also implement another training course for the nursing education.
So lots of investment in that process to allow for kind of nurses to feel comfortable with this. I suppose on that, so we tried to make sure that we were understanding CAR T when it came in, but are there a couple of specific maybe areas that in the world of leukemia and pediatrics leukemia that are frequently misunderstood? Is there anything that you would say that isn't a truth, like a myth? I'm looking for a myth here.
I mean, CAR T is frequently misunderstood, and there is some there is a question of if we have to choose between CAR T cell or hematopoietic stem cell transplantation. I mean, do we have to continue to perform some transplantation to the patient? Because now we have a better understanding of CAR T cells. We are able to manage the toxicities such as cytokine release syndrome, neurological toxicities. So this question, CAR T versus hematopoietic stem cell transplantation, becomes, I think, legitimate. If we can manage this complication, can we imagine offering this new treatment as a first line option? So it's one misunderstood thing. And to try to answer to this very difficult question, very scientific question, you can read a very interesting paper from, I think it's Professor Büchner. I'm sorry if I mispronounce his last name, but that explain the role of CAR T cells, the development of this new treatment in B-cell ILL, and the challenging of CAR T persistence after reinfusion, which is very interesting. And in this paper, they discuss the use of CAR T either as a bridge to transplant or as a single curative option. And they say that when they use CAR T as bridge to transplant, we have to consider that we at that time suggest two extremely costly important treatments in both in terms of financial expense and toxicity. So we have to keep it in mind. And the other option is to use CAR T as a first line option treatment without any consolidation with hematopoietic stem cell transplantation, which is very an attractive approach. However, this approach for children exposed to prolonged B-cell aplasia, which means that these kids will need for long-term immunoglobulin infusions, which is also late toxicities. And moreover, when you use these treatment CAR T cells before transplantation, it carries the risk that unfortunately, in the event of relapse, the patient may no longer express the famous CD19 antigen, which is a real target for other therapies.
Okay, so we've still got some understanding, I suppose, to do to work out what is necessarily the best, but again, it'll be person-centered, won't it? And that paper will be linked in the podcast notes for anybody that's interested in reading it. And I think it's time maybe to move on to the next part. So we'll have a little think about that, and Hilda will ask you some questions.
Yeah, that's a very interesting part, because that's moving to what they don't teach in school. And in this part, we move from theory to practice, actually. And we want to discuss what are the real world challenges nurses face and how can we better support our patients and ourselves. And probably you can share some practical advices for nurses working in pediatric HCT. and something you did not learn in school, but what is the essence of your work?
What they don't teach in school about pediatric acute leukemia.
Could fill a
Everything.
book,
Everything.
maybe.
But I mean, since the beginning of this podcast, we are talking about very challenging topics, scientific topics. We talked about CAR T-cell therapy, HSCT, but we can also add other acronyms such as GVHD, MRD. So that's a lot of acronyms, and we are only partially trained to master them all. So now imagine a family suddenly embarking on this journey. So they are expected to grasp this concept, to handle day-to-day care, to give informed consent, probably to be a bridge to bridge that gap, to translate this very specific scientific knowledge for parents and children. In doing so, probably improve their health literacy, which is a famous concept.
It
But
is, yeah.
basically, we are acting like probably like a mediator to reduce families' uncertainties. I mean, in my daily practice, I always have this in mind, and I'm trying to use two other famous concepts: the empowerment and also the Gottlieb strength-based approach, just to give some keys to this family to take care of their children, because it's very complicated. And I believe this is really essential, because we know that transplantation, hematopoietic stem cell transplantation, is a quite long journey.
Yeah, and you didn't learn this at school, but you faced this in current practice. And how did you master yourselves these topics and how to explain and guide these parents and children?
Well, honestly, it's very hard to it can be hard to do it every day, because you come into a room, you have some stuff to do, sometimes you have to go very quickly, but I mean, you have to also really discuss with your patient to hear the different needs, the family's concerns, and sometimes you can see that they don't understand what you are talking about. You can see that they had an appointment with the physician just before you, and they look completely lost. So, and if you say, okay, so no, I don't have time to deal with it, it's not working. So you have to, I mean, for example, I always asking that, so okay, so let's try to find together your resources. Where is your resources? Do you have family resources? Do you have someone in your family who can help you to understand this discussion? Maybe I can suggest you a specific website, a specific booklet, just to understand better the information the physician gave to you. So this kind of stuff. I use this kind of stuff.
Yeah, excellent and nice to hear. I think we can learn so much from you on this topic anymore, but I had another interesting question, because from what I know in pediatric leukemia, we previously in the past were striving for survival for these patients, but nowadays we do not only want to ensure that they will recover, but also will be healthy and participate in normal life. And can you reflect on that? Because that changed a lot, I think, in the protocols, but also in the care for these patients.
I think it is a very important thing to keep in mind for clinicians, researchers. There is this an also fantastic paper from Mulligan's, and it was a quite old one. I think it was published in 2015, and at the end of the paper you can see an amazing graph with the improvement of overall survival through decades for patients with B-ALL. And now we know that above 90% of these children will survive. So it's excellent. But what is the price? what is the cost of this survive, and specifically if they need hematopoietic stem cell transplantation. So now the idea is to probably think about other treatments without such long-term toxicities. Okay, so for example, you have this study, the FORM trial, who try to replace total body irradiation, because we know that total body irradiation frequently used as a conditioning regimen agent for patients with ALL. We know that there are a lot of several long-term side effects. So the idea of this study was to do not use total body irradiation anymore, but unfortunately TBI remained superior compared to chemotherapy as a conditioning regimen agent. So it pushes probably researchers toward smarter ways to cut toxicity.
Yeah, that was really an interesting outcome which we didn't expect, and actually where we did not hope for, but unfortunately it is. And what you say, it's a topic for researchers that should be further investigated, of course.
It's been on for years, hasn't it? I mean, I think one of the very first transplants ever done was done to a little boy who had acute leukemia, sorry. And he'd had total body irradiation and then transplantation, and then actually didn't survive due to graft-versus-host disease. But you know, this is what we're talking. That was the late 50s, early 60s. So we're 60, 70 years on and still thinking about TBI. Maybe it's time.
Yeah.
Any budding researchers out there, get in touch with Thomas. Let's have a chat.
Yeah, and we of course will mention the paper that Thomas mentioned earlier also in the notes of the podcast. But I think because we are talking about research and future, it's time to move to the next part, which will be news and recommendations. And Emma will cover that.
Okay, so moving on, as Hilda says, to news and recommendations. So we'd love to hear what's going on in the world of leukemia for pediatric patients. And I think we could maybe ask you to talk us to a little bit through the GLA research priorities, if that's all right.
I can try to talk about it. This is a suggestion of top 10 priorities for clinicians and researchers. And it was from a specific group with patient families and also healthcare providers. And you have 10 fantastic top priorities. One of them is to reduce treatment related toxicities, but we already talked about that. But there is other priorities, and which is amazing with that work is this highlights probably the central role for nursing research, because several GLA priorities are clearly nursing led. For example, they are talking about systematically assessing, addressing patient concern, needs across HSCT journey, and basically it's a nursing project. We also talk about they talk about the implementation probably of a pre-habilitation and also rehabilitation program to deal with symptoms such as fatigue, also preserve, rebuild muscles after transplant. And this is a role for nurses, you know.
Yeah, and it's indeed a lot of not only medical topics, but also nursing or more psychosocial topics. And I had the pleasure to be part of that GLA steering committee and GLA, the James Lyne Alliance. And I think, and also I was also joining two of the workshops, and it was really interesting to hear also the patients and families' input to prioritize these research settings. And it's nice that it ended up with such a nice mixture of kind of topics. So it's a nice opportunity for research to see what priorities were set, and as an opening to move on with your research.
Yes,
well, it sounds like, I was going to say, it sounds like there's a lot of support in this podcast for some nurses out there to take on some research. So we will also, in the podcast notes, link those top 10 GLA research priorities for anybody that might be interested in looking into that. Okay, so moving on to the sort of final part of the podcast, and I'll ask Hilda to maybe talk about this topic. And you'll probably have some things to say about this too, Hilda, being that you are a pediatric nurse.
Yeah, thank you, Emma. I'm really a pediatric nurse, of course. I am. I'm unfortunately not involved anymore in pediatric leukemia because I'm now only involved in non-malignant or non-oncological diseases.
You've got a lot of hats, Hilda. You know a lot of things.
Yeah, but this part is focusing actually on the patient's perspective. And I think that's a really important part because, that's what brings us also further. And that are the voices that matter most, I think, are our patients.
Agreed.
Because they can tell us what they wish we should know, and how we can be better aligned to clinical care with their lived experiences. So I actually was wondering, Thomas, if you have a case that illustrates some of the challenges that we have discussed today, and probably you have such a case in mind.
Oh yeah, I'm thinking about a case. It's not a very good story because finally, unfortunately, this patient passed away. But I learned a lot with her. She was very inspiring, and she had a acute lymphoblastic leukemia, a B-cell ALL. So she received a first-line treatment, including chemotherapy. And I was a young nurse, so I've learned how you infuse chemotherapy, how you watch for side effect. I also learned to talk to a young girl, to talk to a mother, to talk to a father, brothers and sisters. So it was very important at the beginning of my career. Unfortunately, this patient relapsed several years after, and at that time she was we didn't have any curative option to suggest, and she continued to live with the disease controlled by a low dose of chemotherapy. And one day CAR T cells comes up, and we were able to infuse CAR T cell therapy. So imagine for a family, physician say that we don't have any curative option, and from one day to other it changes. It's not palliative care, it's curative care.
Yeah.
We are suggesting right now a new intensive treatment. And it was very interesting to be able to to be with this family, to deal with this very new situation. And at that time I was also APN student, so a lot of years after the beginning of her treatment. So I've learned my new job with her. I've learned to perform a clinical exam. I've learned to how I was supposed to conduct like a medical consultation, to prescribe treatments, and it was very helpful because we were playing together, and the parents were so supportive with me. So together we learn how to deal with to live with the leukemia, with treatment, to watch side effect, to receive a new treatment, and finally, unfortunately, at the end, how we have to talk about palliative care, how we have to talk about death to a young kid. And it was it's not like a good story because unfortunately she passed away, but I had no regrets with this patient. We lived a fantastic experience, and she really leading my practice right now. So this is my case.
Yeah, and I can still see that she's still in your heart, and I know that
forever.
I think it's for all of us nurses that we carry a lot of our patients in our heart, and especially I think when we have such a long story with patients, you cannot forget those experiences and those patients and parents as well. So yeah, thank you for sharing this special case, because I think it's you learned a lot in this situation, and but also have a lot of memories.
Of
here.
Course.
Yeah, it's a lovely case, Thomas. It's a lovely one, and a sad outcome, but We see this, don't we, unfortunately?
Yes, it's also real life, you know.
It is.
Mm.
It is.
Yeah, and
it's not-
sometimes it is also in how to integrate those aspects into your work as well. And as you said, you learned also from that experience how to include palliative care, and in talking with children about these aspects is that are also part of our job, not
Yeah,
the most
it is.
easy
As a
ones.
pediatric nurse, it is.
Yeah, and it is also a very important one, especially for parents because they have to live with these experiences as well. I
Yeah,
think
you guys look after the patient and the parents and the brothers and sisters and the grandmas and grandpas. I think in the adult world we are sometimes a little bit easier, and sometimes it can just be the patient and the partner, or probably
I
less
wouldn't say that it is probably easier or different. It's different because you
different.
always also
Yeah.
take care of family carers. I think that's
Yeah.
I think we share definitely, and it's not that it is more special. It's different, but it's not better, more special. But yeah, that's nice. Yeah, and I think, do you have one final lesson you learned, or do you have one final lesson you want to share with
One
all
last
the
thought.
nurses? Yeah, one last thought.
Well, the theme of this podcast is advances in pediatric acute leukemia. And if we are looking back, I mean, if I am looking back, I realize that the past 15 years have been truly remarkable, with real medical breakthroughs, nursing innovation also, that I completely reshaped our practice. And what is truly remarkable about this specialty is that within a relatively short time frame, we have witnessed so many medical advances. So I hope the next 15 years will be just as promising.
I'm sure.
Yeah, I'm sure if we interview you in 15 years or over 20 years, then we will have a different conversation, but still very exciting.
That'll be podcast number 792 or something
Okay,
at that point.
let's schedule it right now.
Yes, absolutely. I'm sure the EBMT background team is shaking their heads at us right now. Well, listen, really want to say thank you so much for joining us today, Thomas. It's been absolutely brilliant seeing you again and hearing your perspectives on this, and learning a bit about what Hilda's experiences are as well from my perspective. So thank you so much for joining us.
Thank you so much.
Thank you very much. Thank you very much.
Thanks, Hilda, for being my co-host again. It's been lovely.
It's my pleasure.
Again. I want to thank the listeners. Obviously, you guys for listening to us every time you do. That's absolutely wonderful. We feel very special. And we have to thank the background team for all their hard work for making sure that this podcast is there and out there and ready for you guys to listen to. So thanks so much.
And probably if you want to have an interesting thought or an interesting question, probably from a patient perspective, don't be shy to put those questions or thoughts in the notes of this podcast, and we can probably come back on it next time. So, and thank you, Emma, for co-hosting this.
Oh, you're very
podcast.
welcome. And I think absolutely right. Make comments. Tell us what you thought. We're very interested to hear your thoughts on the topic we covered in this podcast today. What would you add from your experience? It would be great to hear from you either via the email on the EBMT website, title your comment Blood Matters, or you can leave a comment on YouTube. Don't forget to have a look at the resources that we mentioned in this podcast episode today. Thank you so much for joining us, and until next time.